Welcome back to the deep dive. This is where we take those, impossibly dense orthopedic research papers and imaging guides and turn them into something you can actually use in the clinic tomorrow. I'm playing the role of the surgical resident today. I'm the one looking at this huge stack of post-op films, trying to figure out, is this painful knee just a simple alignment problem, or is it something a lot worse?
And I'm here to guide you through it. I'm ready to really dissect the painful total knee arthroplasty. It's such a fascinating problem because, let's be honest, TKA is one of modern medicine's biggest wins. Our sources all agree. For over 90% of patients, it's a life-changing improvement in their quality of life. But that success means we're just flooded with imaging studies. Every single day, we're looking at a patient who's post-op and still in pain.
Exactly. So our mission today is not just a basic, is the hardware in the right spot review. We're going to assess the entire diagnostic toolkit. We're talking radiography, CT, MRI, and the really critical role of nuclear medicine. And we're going to learn how to systematically tell the difference between what's just normal post-op healing, what's a simple mechanical failure, and, the one we all worry about. That stealthy, creeping threat of a periprosthetic joint infection.
That systematic approach it's everything. I mean, the sheer amount of information and just how complex these cases can get, it requires a really efficient, cost-conscious, and effective diagnostic strategy. You, as the doctor seeing that patient, you need to know almost instantly which tool. Is it the simple X-ray? Is it the fancy MRI sequence? Or is it time for the nuclear scan? What is the right next step to either rule out or confirm your suspicion?
Okay, so basically we're not just looking at a car that's broken down. We're running a kind of high-level diagnostic triage. We need to figure out if the car just has misaligned tires, a geometric mistake, or if the tires are bald and shedding material, which is particle wear, or if the whole engine is getting contaminated with some kind of low-grade infection. It's complicated, but it's absolutely essential stuff.
Okay, let's unpack this. Let's start at the very beginning. The blueprint for a perfect knee. So before we can even begin to diagnose a failure, we have to know what success, what perfection looks like on an X-ray. Let's talk about preoperative planning. All of our source material really hammers on the need for not just the standard AP and lateral views, but also these full-length standing AP radiographs of both legs, hip to ankle. Why is that specific full-length view so non-negotiable?
Because the goal of a TKA isn't just to make a perfect knee, it's to build a perfectly balanced limb. We absolutely need that full-length film to define the relationship between the two critical axes of the leg, and that's the anatomical axis versus the mechanical axis.
Okay.
The anatomical axis is what you think it is. It just runs right down the center of the bone, the intramedullary canal of the femur or the tibia. But that's not where the force should be going.
The force has to follow the mechanical axis. Precisely. The mechanical axis is that straight line you draw from the center of the femoral head all the way down to the center of the talus. It is effectively the weight-bearing line of the entire limb. And what we need to know is where that mechanical axis crosses the knee joint. In a healthy, normal leg, that line should pass right through the center of the knee, or maybe just a little bit medial to it. This one measurement dictates everything we do in the OR.
And if we're looking at the femur, the anatomical axis and the mechanical axis aren't the same line, right? They're naturally offset, which creates that physiological valgus.
Exactly right. The angle between the anatomical axis of the femur and that mechanical axis is, pretty consistently, about 5 to 8 degrees of valgus. So when we get in there to cut the distal femur, we have to account for that offset. We might reference the anatomical axis, using the canal, but we make our cut to align with the mechanical axis of the limb. That 5 to 8 degree angle is the whole key to planning that femoral cut, so we can recreate a neutral mechanical alignment. We want the force going straight down the leg.
Okay, but this brings up a really interesting point I saw in the source material, what they called the planning paradox. I saw some studies, one by McGrory et al., that really questioned if those big full-leg standing films were all that useful. They suggested they didn't really improve our chances of hitting a truly neutral mechanical axis compared to just doing a standard femoral cut referenced at, say, 5 degrees. I mean, if even the gold standard method is up for debate, are we just chasing an impossible ideal here?
That's a very, very sharp clinical question. And it gets at the inherent messiness of measurement. There was another study by Huang et al. That showed that just the manual measurement of the mechanical axis, even on a perfect film, can have an observer variability of 1 to 3 degrees. So yes, even with the best possible films, you're working with an imperfect tool. The point of the planning isn't just to hit one magic number. It's to understand that specific patient's unique anatomy and deformities. especially if you have a big varus or valgus deformity way beyond the normal range. So you can adjust your technique in the moment. You just need the full picture before you make that first cut.
I like that. It's more about clinical judgment than just blindly following a number. It makes sense. Aligning the knee is kind of like making sure the foundation of a house is perfectly level. If it's off by even a few millimeters,
Yep.
the whole structure, the patient's gait, their function, the life of the implant, it all starts to crack down the line.
Now, checking the work is where the imaging really starts. But we have to be disciplined about the timing. You mentioned those immediate post-op supine x-rays.
Right.
They are, and I want to be clear, fundamentally unreliable for assessing true mechanical alignment.
Why is that?
Because the patient is lying down. They're not weight-bearing. Their muscle tone is all off. The true, definitive alignment is only revealed on the standing, weight-bearing radiographs you get later, usually at that first post-op visit. Trying to diagnose an alignment failure on a film from the recovery room is, often a waste of time.
And the stakes for getting that post-op alignment check right are huge. I mean, the data shows that coronal malalignment leads directly to decreased implant survival and much faster polyethylene wear. So what are the specific radiological goals we're measuring on those standing films?
We have very stringent goals, both in the coronal and the sagittal planes. You can see it laid out in figure 13.1 in our source. In the coronal plane, the goals are actually pretty simple.
Yeah.
The femoral component has to be perpendicular to the mechanical axis of the femur.
Okay.
And the tibial component should be perpendicular to the anatomical axis of the tibia.
And what are the acceptable tolerances? Because you just said there's inherent measurement error of 1 to 3 degrees.
The clinical tolerance is incredibly tight. Any deviation from that neutral mechanical axis should be minimal. Ideally, you want to be within 3 degrees overall. But listen to how tight some experts define it. Acceptable alignment is cited as being within the range of 1 degree of varus to 2 degrees of valgus, just a tiny window. Outside that 3-degree window, you see much higher rates of loosening and revision. You're just accelerating wear on one side of the plastic liner, concentrating all that stress, and you're basically cutting the implant's lifespan in half.
That is a very, very tight window. It really confirms that TKA is a feat of precision engineering inside a very dynamic biological system.
Now let's switch to the sagittal plane and look at tibial slope on the lateral view. This is another area where, a subtle error can cause some major mechanical problems. We're looking at the posterior or inferior tilt of the tibial component. Now, if you have an increased downslope, especially with a PCL retaining component, you might get great flexion initially, but there's a big mechanical price to pay for that. Excessive tibial downslope, it risks anterior tibial subluxation. The tibia can actually slide forward on the femur, which feels incredibly unstable to the patient. It also grinds away at the posterior polyethylene because the femoral component is constantly pushing back on it. And maybe most frustrating of all, it can cause a critical lack of full extension. It's a classic surgical trade-off. You're chasing maximum flexion, but you're sacrificing stability and the longevity of the implant.
So on every single TKA film, we have to measure coronal alignment and sagittal slope. Both of them define that balance between function and mechanical longevity.
Which brings us to what is, I would argue, the single most common source of persistent post-op pain. The patellofemoral articulation. The sources are crystal clear on this. The patellofemoral joint is a massive cause of post-op pain and even prosthetic failure. We can have perfect femoral and tibial alignment, and yet the patient is miserable because of a patella tracking issue.
And this all goes back to restoring the joint line height, right? Because if you change that, you change the entire lever arm for the quad.
Precisely. Restoring that joint line height is absolutely paramount. The classic data from Figge et al. Showed a direct link. Functional scores, range of motion, and just the absence of patellofemoral pain were all significantly better when the joint line height was restored to within 8 millimeters of the native height. You're restoring the natural fulcrum of the knee. Huffman and his group advocated for using the adductor tubercle to the joint line distance for measurement. The goal, the clinical goal we all shoot for, is to restore that joint line to within 4 millimeters of the native side.
And what happens if we miss that 4 millimeter target? I mean, what are the immediate consequences if the patella ends up too high or too low?
You're inviting severe dysfunction. If you lower the joint line, say by using a thin tibial component, you risk patella baja low-riding patella. This just cranks down on the extensor mechanism, it restricts flexion, and it creates these massive compressive forces on the inferior part of the patella. If you raise the joint line, you get patella alta, or a high-riding patella. And that often leads to poor tracking, mid-flexion instability, and that awful patellar clunk you sometimes hear about. The patella has to track smoothly, and changing the joint line height just throws the whole system into chaos.
And it's not just about the vertical height. We also have to worry about the fit, right? Specifically rotation and thickness. I saw one study that reported patellar tilt in over 31% of primary TKAs. That's almost 1 in 3 knees.
It is rampant, and it's a failure of either rotational or translational positioning. You measure patellar tilt relative to the anterior femoral condyles. When that patella tilts, usually laterally, it drastically changes the contact area. So instead of the force being spread out broadly across the center, all the force hits this tiny, thin, highly stressed peripheral part of the patellar button.
Which goes right back to particle disease, doesn't it?
Exactly. That concentrated stress creates localized PE deformation, you get particle shedding, and you get premature mechanical failure. You have to look really closely at those tangential or sunrise views to catch this. It can look totally fine on the AP and lateral.
Okay, and finally, this idea of overstuffing. How do we define that on an X-ray, and what's the functional result?
Overstuffing is just what it sounds like. It's when the resurfaced patella is thicker than the native patella was, or when you put in an oversized femoral component that impinges on the soft tissues. Clinically, a patellar thickness greater than about 26 to 28 millimeters is considered abnormal. Functionally, what happens is it increases the pressure on the lateral retinaculum and all the soft tissues around the joint. When a patient comes in complaining of stiffness, poor tracking, and just this anterior knee pain because the joint literally feels too full, it's a simple geometric error that the soft tissues just cannot tolerate.
Okay, so once we've established that the static geometry looks good, we have to start hunting for the failures that happen during motion. And that brings us to section 2, the mechanical problems that often need more advanced imaging to really pin down.
And rotational malalignment it's truly the invisible killer. Plain X-rays are fundamentally incapable of measuring it, yet we know it's linked to pain, stiffness, instability, and really severe patellofemoral problems. This is often the patient whose X-rays look beautiful, but they're still telling you they had this debilitating anterior knee pain or a feeling of catching.
And the imaging challenge here is huge. CT is the gold standard, but I've read that even the reference points people use for measurement are really controversial. So how do we find reliable landmarks to measure component rotation accurately?
We have to rely on established anatomical axes, and the method laid out by Berger and his group is crucial for this. Let's start with the femur. The femoral component's rotation has to be referenced to the surgical transepicondylar axis.
Can you just remind us what that is exactly?
Of course. It's the line that connects the most prominent points of the medial and lateral epicondyles. To be really precise, it connects the lateral epicondyle to the medial sulcus of the medial epicondyle. This line is the anatomical flexion-extension axis of the knee. So ideally, your femoral component should be parallel to this axis, or even better, slightly externally rotated by about 3 to 5 degrees. That really optimizes patellar tracking. If you put that femoral component in internal rotation, you've immediately created maltracking and you're cranking up the patellofemoral contact forces.
And what about on the tibial side? What's the anchor point there?
For the tibia, you reference the tibial tubercle. It's easy to feel and easy to see. Berger's work established that the native tibial joint surface, and therefore a correctly placed tibial component, should sit in about 18 degrees plus or minus 2.6 degrees of internal rotation relative to that tubercle. This makes sure the patellar tendon insertion is properly lined up with the groove on the femur.
So the problem isn't just one component being off, it's the cumulative mismatch between the two of them.
Oh, absolutely. It's like a spiraling misalignment. The most destructive failures happen when you have combined errors. Berger's group found a direct proportional link between how bad the patellofemoral complications were and the degree of combined internal rotation.
Meaning the sum of the errors on both sides.
Exactly. The sum of the internal rotation error on the tibia plus the internal rotation error on the femur.
That cumulative effect is really the key. Malrotation sounds like trying to drive a car when the front axle is pointing a little bit to the right and the back axle is pointing a little bit to the left. You can still go forward, but the tires are just constantly scrubbing against the pavement and everything is fighting itself. That chronic, unnatural friction, that's the patient's anterior knee pain, their stiffness, and eventually the early mechanical wear.
And moving from alignment to material science, we have to talk about particle disease. This is the primary biological driver of long-term TKA failure.
Can you walk us through that mechanism? Because it sounds like it starts as a mechanical problem but ends as a biological one.
It's an immune system revolt, basically, triggered by microscopic bits of plastic. The polyethylene liner wears down and generates these tiny particles, submicron debris that floats out into the tissues around the joint. The body sees these particles as foreign invaders, and it launches this massive chronic inflammatory attack. You get a release of inflammatory cytokines, which then viciously stimulate osteoclasts, the cells that eat bone, while at the same time inhibiting osteoblasts, the cells that build bone. You tip the balance entirely towards bone destruction. We call that process osteolysis.
And radiographically, on our x-rays, how do we track this wear and the osteolysis that might follow?
We start with our standard standing AP and lateral views, and it is critical that the X-ray beam is perfectly parallel to the tibial base plate, otherwise you get parallax errors. This lets us measure the distance between the femoral condyles and the tibial base plate. You can see it in figure 13.0. If that distance is getting smaller over a series of films, we know that plastic liner is wearing thin. If it gets really bad, you could eventually see metal-on-metal contact, erosion of the metal backing, and even metal synovitis if you start getting cobalt chrome debris in there.
Now let's talk about the hallmark sign of loosening. Radiolucent lines, or RLLs. This is always confusing for residents. What visually and over what time frame distinguishes a normal, benign RLL from a pathological one?
This is a crucial distinction. It's what separates routine follow-up from we need to plan a revision. A thin RLL, meaning less than 2 millimeters wide, right at the bone cement or bone prosthesis interface, can be totally normal. Oh yes, we expect to see them in the first 6 months for cemented implants, or even up to 1 or 2 years for non-cemented ones, as the bone is just adapting and settling. The key word here is non-progressive. If a lucency shows up and then it just sits there, stable and thin, it's usually benign. It's just a reflection of some minor settling.
So when do we hit the panic button and call it pathological loosening?
We get concerned when the RLLs meet specific criteria. First, if they're focal and wider than 2 millimeters. Second, if they're clearly getting wider or longer over serial films. Third, if you see an associated crack in the cement mantle. Or fourth, if there's any discernible change in the component's position. Clinically, the tibial component loosens way more often than the femoral one, and it tends to subside into the medial plateau, shifting into a virus position. You have to look for that progressive change over time.
And how do we tell those RLLs, which mean there's a failure at the interface, from stress shielding? They can both look like areas of radiolucency.
They are fundamentally different processes, and they look different. Stress shielding is just Wolff's Law in action. It's a diffuse decrease in bone density. In areas around the implant that aren't seeing as much mechanical load, the bone is just resorbing where it's not being stressed. The key visual difference is that stress shielding does not have that thin sclerotic white line that often borders pathological RLL. It's more of a hazy, diffuse decrease in density.
And what about over time? How do they behave differently?
Stress shielding usually stabilizes within the first 2 years, often even earlier. It's an accommodation, not a failure. Pathological RLLs, the ones caused by mechanical toggling or a biological response, they will progress continuously. So if you see a diffuse decrease in density that hasn't changed between the 1 year and the 2 year film, you can be pretty confident it's just stabilized stress shielding.
Yeah.
If you see a line that was 1 millimeter at year 1 and it's 3 millimeters at year 2, well, that's failure until you prove it's not.
So as we've said, plain x-rays have their limits. They're not great when osteolysis is small or hidden behind the implant. This is where we need advanced imaging, and that brings us right up against the biggest technical problem. Metal artifact. Let's start with CT. How do we get around the artifact problem there?
CT is excellent for looking at bone, especially for spotting those focolytic lesions. To cut through the metal, we use specific technical tricks. Higher kilovolt peak settings, usually around 140 kVp, to get better X-ray penetration. We also use specific soft tissue reconstruction filters and wide window settings. These little tweaks really improve the image quality right next to the prosthesis, and they're great for mapping out the exact size and shape of osteolic lesions.
But the real leap forward in diagnosis has come from beating metal artifact on MRI. I mean, traditional MRI sequences near metal are often just a mess of signal loss and distortion.
Precisely. We're fighting 3 things with metal in an MRI susceptibility artifact, which is the signal loss, geometric distortion, and failure of fat suppression. Now, basic things like increasing the bandwidth can help a little bit, but there are 2 pulse sequences that are the true technological heroes here. They've completely revolutionized how we see soft tissue around an implant, hemiviric and CMAC.
Okay, let's take a minute to really unpack those acronyms. This is where the physics gets really cool. What is hemiviric?
Hemiviric stands for multi-acquisition variable resonance image combination. So think of the metal implant as a huge magnet that's locally warping the magnetic field. A traditional MRI scans with just one frequency band. Emmerich's approach is to say, I can't beat the distortion, so I'll just scan multiple times using slightly different frequency bands offset from the main one. It then intelligently combines all those data sets. By gathering data across a wider range of frequencies, it massively reduces the signal voids and the geometric shifts caused by the metal.
That makes sense. It's sort of scanning around the distortion instead of trying to scan through it. So what's CMAC's strategy?
CMAC, or slice encoding for metal artifact correction, is different. This technique uses additional slice encoding steps. It's similar to how we encode spatial information in X and Y, but it adds a third encoding direction along the Z-axis, specifically to correct for the field problems caused by the metal. It's a very complex spatial correction that's incredibly effective at reducing that geometric distortion.
And what's the clinical payoff for us? I mean, why go through all the time and expense for these fancy sequences?
The payoff is phenomenal sensitivity for soft tissue pathology right next to the implant. Studies comparing MEVR to standard imaging showed significantly better visualization of the bone-metal interface and all the periprosthetic soft tissues. It lets us detect pathology much, much earlier.
And specifically for particle disease, this means MRI is the best tool for identifying those osteolytic lesions, the granulomas, and the synovitis that goes with them.
Yes. MRI is just superior for finding those focal, well-defined areas of bone destruction, the granulomas. On an MRI, they show up with this intermediate signal intensity, and they represent the inflammatory tissue that has just replaced the normal fatty marrow. You can see it in figure 1313. And crucially, MRI can also spot the intense inflammatory synovitis that often happens before you can see any bone loss on an X-ray. This makes it an invaluable tool for watching for particle disease. If you see a big soft tissue mass around the joint, even if the bone looks okay, that is highly suggestive of a granuloma forming.
Okay, now we have to move to the ultimate clinical question. Is this painful knee failing because of a mechanical problem where malrotation, aseptic loosening, or is it because of a silent festering infection? This is the high-stakes game.
The stakes could not be higher because the way they present can be almost identical. Infection complicates somewhere between 0.8 and 1.9% of all TKAs. And we have to remember, infection is the #1 cause of failure for early revisions. Revisions done less than 2 years after the initial surgery. Aseptic loosening is what dominates the late revisions.
So what's the one symptom that should immediately make us think infection?
Pain, but specifically night pain or pain at rest. Aseptic loosening usually gives you mechanical pain. It hurts with activity, with weight bearing. Infectious pain is often inflammatory, it's constant, and it wakes the patient up at night. That is the single most critical piece of history you have to get from the patient.
Okay. And moving on to the lab work, the most common test is the CRP, the C-reactive protein. We really need to understand its normal behavior after a TKA to interpret it correctly.
This is a common trap for new clinicians. CRP levels are, of course, elevated after any big surgery, but they should return to normal, which we usually define as below 10 within about 2 months. So a normal CRP 2 months out pretty much rules out an acute infection. But if that CRP stays high, or if it goes down and then comes back up, specifically if it's 13.5 or more, that becomes a highly sensitive indicator for an infected TKA. We're talking 73 to 91% sensitivity.
And the AAOS guidelines say if the ESR and CRP are abnormal, you move right to joint aspiration. Aspiration is the clinical gold standard for confirmation, but it's far from perfect.
It has some significant pitfalls. Our sources point out that knee aspirations are, unfortunately, more likely to give you a false negative result than hip aspirations. And the #1 reason for that is prior antibiotic use. You need a good watch-out period, at least 2 weeks, sometimes even a full month off antibiotics before you do the aspiration to have the best chance of growing something. If the patient is already on chronic antibiotics, you may be forced to use advanced imaging or even just take out the hardware to get a definitive diagnosis.
So if the clinical picture and the labs are still confusing, how much faith should we put in a standard X-ray to diagnose infection?
Frankly, very little. Radiographs are generally insensitive for prosthetic infection. The problem is that the signs are the same. The radiological signs of infection, progressive loosening, osteolysis, widening radiolucent lines, they look exactly like the signs of severe aseptic loosening from particle disease. You can even have a nasty infection, like a low-grade biofilm infection, with a completely normal-looking X-ray.
So we turn back to our advanced tool, MRI. Can those MA-Vieric and CMAX sequences give us a specific sign for infection that aseptic loosening doesn't usually have?
Yes. And this is where MRI can provide crucial specificity. It goes beyond just spotting granulomas. The key finding for infection is the presence of lamellated hyperintense synovitis. You can see a great example in figure 13.1's TNF. This refers to a thickened, multilayered synovium that shows a really bright signal on intermediate weighted images.
And what makes that layered, lamellated pattern so specific to infection?
It represents the intense, highly organized inflammatory response you see in a chronic septic process. It's like the layering effect of fibrin and inflammatory cells inside the synovium. Aseptic inflammation is often just diffuse and messy. Septic inflammation tends to be more aggressive and organized like this. Experienced radiologists report this sign to be highly sensitive and specific for paraprosthetic knee infection. If you see it, even if your first aspiration is negative, you need to stay highly suspicious.
Okay, so if the clinical picture, labs, and even our best morphological imaging are still ambiguous, we have to move to the functional studies of nuclear medicine. Let's start with the cheapest and most common test, a bone scan.
A standard bone scan using technetium-99-meter diphosphonates is highly sensitive for any kind of failure, but it's fundamentally useless for telling you the cause of the failure.
So it's a good screening test.
It's a fantastic screening test. A negative bone scan makes infection or loosening highly unlikely, but a positive one just tells you the joint is unhappy. And the problem is post-surgical remodeling. The work by Rosenthal et al. Showed that increased activity persists around over 60% of femoral components and almost 90% of tibial components for more than a year, even in patients with zero symptoms.
So a hot bone scan is basically the same as the patient saying, yes, my knee still hurts. It has no specificity.
Exactly. It shows metabolic activity, but that could be from normal healing, mechanical stress, aseptic loosening, or infection. Doing a three-phase study doesn't really improve the specificity enough to reliably separate aseptic from septic loosening.
And that is precisely why we have to turn to the gold standard for specificity, combined labeled leukocyte and marrow imaging. Now, this test is based on a principle of functional incongruence that is just genius. Can you walk us through that two-step process?
This is truly the definitive diagnostic work. It separates active infection based on cellular function. It relies on comparing two separate scans using two different radiopharmaceuticals injected one after the other.
And what are those two agents? What do they track?
First, we take the patient's own blood, separate out the white blood cells, and we tag them with a radioactive tracer, usually indium-111 or technetium-99 meters. We then inject these labeled leukocytes, or WBCs, back into the patient. The WBCs track infection because they are drawn to the site by chemotaxis. Second, we inject technetium-99 meters sulfur colloid. This is our marrow imaging agent. Sulfur colloid is taken up by the reticuloendothelial cells, the normal cellular parts of the bone marrow.
Okay, so in a normal situation, both agents should light up in the bone marrow. What happens in an infected joint that creates this incongruence?
This is the critical part. In a normal knee, or even one with just aseptic loosening, both the WBC scan and the marrow scan show a similar distribution of activity. They are congruent. They both light up the bone marrow because the marrow is still functioning normally.
But infection disrupts that balance.
Yes. In a truly infected joint, two things happen at the same time. First, the powerful chemotactic signal from the infection aggressively pulls in all the labeled WBCs. You get a very hot spot on the WBC scan. Second, the active infection and chronic inflammation actually suppress the normal function of those reticuloendothelial cells in that area. So the uptake of the sulfur colloid, the marrow agent, is suppressed.
So you get a strong signal on the WBC scan, but a weak or absent signal in the exact same spot on the marrow scan. The images are spatially incongruent.
Precisely. The abnormal activity on the leukocyte image does not match the normal marrow distribution on the sulfur colloid image. You can see it in figure 13.22. It is the absence of the normal marrow signal, despite the presence of the inflammatory cell signal that confirms infection. It's like checking for a fire by looking for both smoke, which is the WBCs, and the lights on at the fire station, which is the marrow function. If you see a ton of smoke but the fire station is dark, you know something is wrong with the system itself.
And the clinical accuracy really backs this up.
Absolutely. Palestro and his group reported that WBC marrow imaging was 89% sensitive and a stunning 100% specific for prosthetic knee infection. It is the definitive separation tool, far superior to any single-agent bone scan.
Now let's quickly contrast that with FDG-PEEK, which we hear about all the time for inflammation, but it struggles here.
Right. FDG-PET tracks glucose uptake. Inflammatory cells use a lot of glucose. The problem, as we've already discussed, is that severe aseptic loosening from particle disease also causes an incredibly intense inflammatory response with a massive influx of leukocytes. Because both aseptic loosening and active infection cause intense inflammation, FDG just can't tell them apart. The FDG uptake doesn't tell you why the cells are there, only that they're metabolically active.
So FDGP gives you a beautiful picture of the inflammation, but its specificity for prosthetic knee infection is low, often around 75% or even worse, making it a poor substitute for the elegant incongruence principle of WBC mirror imaging.
And, just confirming there's an infection often isn't enough. We need to know exactly where it is so we can plan our surgery.
And that leads us to the evolution of nuclear imaging, SPECT-TCT.
Single photon emission computed tomography SPECT, combined with anatomical CT on the same machine. This fusion imaging combines the functional data, where the radioactivity is, with the precise anatomical detail of what the bone looks like.
And what's the ultimate clinical benefit of SPECT-TCT in this situation?
It significantly improves our diagnostic confidence and the accuracy of the test because it solves the localization problem. The CT part lets us accurately map that functional uptake to a specific anatomical region, say, a focus of infection that's only in the tibial stem, or one that extends out into the soft tissues. This allows us not only to confirm an infection, but to precisely guide our surgical plan, which is invaluable if you're planning a debridement or tissue sampling. Using a great example of this in figure 13.23.
Okay, so we've systematically covered the big three: bad geometry, mechanical failure from loosening or wear, and infection. But before we close the case on a patient with persistent, unexplained pain where the workup is negative, we have to talk about diagnostic tunnel vision. What about non-arthroplasty problems, like, say, a primary tumor?
That's when the surgeon has to zoom out and remember that the hardware is just one part of the patient's leg. While it's rare, masses around the knee can be symptomatic and can mimic infectious pain or mechanical irritation. So we'll transition to benign primary bone tumors, focusing on the two most common cartilaginous lesions we see around the knee.
The osteochondroma. It's the most common primary bone tumor, making up a huge 25 to 50% of all benign bone tumors. And about 40% of them happen right there, around the knee joint.
It is essentially a bony outgrowth that arises from the surface of the bone. The absolute key defining imaging feature that we look for is cortical and medullary continuity with the underlying parent bone. It has to share the same bone structure as the bone it's growing from.
An osteochondroma is like a tree growing out of the side of your house. It's physically connected to the structure, not just sitting next to it.
That's a perfect description. And the primary clinical concern, especially for patients who have multiple lesions, is the risk of malignant transformation.
And for a patient who has a TKA, we need to know what that worrying sign of malignant transformation to sarcoma looks like.
Absolutely. For a single lesion, the risk is incredibly low, less than 1%. But for patients with multiple hereditary exostoses, that risk jumps significantly, somewhere between 3 and 25%. Therefore, the critical measurement for risk is the thickness of the cartilage cap.
How thick is too thick?
A cap thickness greater than 2 centimeters is associated with a significantly increased risk of malignant transformation. A standard X-ray is often useless for measuring this unless it's heavily calcified. This is why you need an MRI or a high-resolution ultrasound for an accurate cap measurement. It gives you the best view of that cartilaginous component. We're looking for that thick, irregular, bright layer over the bony stalk.
Now we have to differentiate that from its cousin, the enchondroma.
Right. An enchondroma is also a benign tumor made of cartilage lobules, but it's typically found centrally inside the medullary canal of long bones, very frequently in the distal femur.
And the classic theory was that these were just displaced cartilage cells from the growth plate during development. Is that still the thinking?
That traditional idea is still taught, but there's new genetic evidence pointing to a molecular cause. Recent studies have linked up to half of all low-grade cartilage tumors to mutations in the IDH1 and IDH2 genes, which suggests a different origin than just simple displacement.
So if an osteochondroma is the tree growing out of the house, an enchondroma is more like a forgotten storage box full of spare cartilage lobules that's been tucked away inside the bone marrow. It's usually just minding its own business unless it causes a fracture.
Exactly. They're often just incidental findings and are generally asymptomatic unless they compromise the bone's structural integrity. But recognizing their benign look on imaging, often calcified with that classic punctate or ring and arc pattern, is essential to rule them out as the cause of pain in a post-TKA knee. We have to systematically check every box that could be causing that chronic discomfort.
That was a phenomenal high-fidelity tour of post-TKA imaging. Let's just quickly review the 4 essential checkpoints we've established today. This is really critical knowledge for every physician managing these complex patients.
We started with the geometric foundation. Accurate TKA relies on defining that mechanical axis from the femoral head to the talus, as we saw in figure 13.2, and ensuring the components are perpendicular to it. And we emphasize that tiny acceptance range, ideally 1 degree of RS to 2 degrees of valgus, to prevent mechanical overload.
Then we hit mechanical failure, recognizing the primary long-term threat is particle disease leading to osteolysis. We learned how to separate normal stress shielding, which is that diffuse lucency, from pathological loosening by finding those progressive radiolucent lines, or RLLs, that are focused and wider than 2 millimeters, which tells you the implant-bone interface is failing.
And we learned how to beat the metal artifact problem with advanced MRI like M of Rick and CMAC. This gives us that superior artifact-free view of osteolytic granulomas and the soft tissues around the implant that traditional scans just couldn't see, which really improves our surveillance.
And finally, the high-stakes game. Infection versus aseptic loosening. We established that while a general bone scan lacks specificity, the definitive diagnostic test is the combined WBC marrow imaging. In an infection, the images are spatially incongruent. The WBC uptake is there, but the marrow uptake is suppressed, as in figure 13.22, and that proves there's a specific active septic process.
Our deep dive today really reinforces the crucial role of multimodality imaging. You cannot rely on a single film or a single lab test. The complexity of a painful arthroplasty demands a systematic, step-by-step process that combines a meticulous history. Is it night pain or mechanical pain? Accurate lab interpretation, and then grabbing the right imaging tool for the specific pathology you suspect.
So here's a final provocative thought for you to take with you as you review your next complex knee workup. If TKA failure rates due to polyethylene wear have dropped significantly in the last decade because of better material science, but infection remains this persistent common cause of early revision, how are we going to further refine our diagnostic strategies, and maybe more importantly our surgical protocols, to drive that infection rate down to 0? Especially given how specific our modern PJI definitions are now, like those from Barvisi's group. The diagnostic tools are getting sharper, but the fight against biology is far from over.